We can't lose patients because of minor things. That we cannot and that we must not accept.
Talk about obstetric hemorrhage, particularly antepartum hemorrhage. Obstetric hemorrhage has been a major problem in South Africa in general. If you look also at the Saving Mothers Report 2017, obstetric hemorrhage is still a significant contributor of maternal deaths in South Africa. Now, the MEC and everybody have actually said that no woman, rich or poor, must die while giving birth as a result of a complication related to pregnancy or not, but no one is supposed to die in pregnancy. When somebody is pregnant, we always say these women are, we use the term, say they are expectant. And the reason for that is because when somebody is pregnant, the whole community is expecting a child, the family is expecting a child. Everybody is expecting this woman to give rise to a healthy baby, and the mother also would be happy. And therefore, it is our duty as healthcare professionals to fulfill that function and make that expectation possible, not only for the mother, but for her family and for the community. So we are there to make sure that we fulfill the idea or the expectation that the community has about the mother. We've already seen from the Saving Mothers Report that women are dying because of obstetric hemorrhage. And obstetric hemorrhage, whether antepartum or postpartum, is an emergency. And the problem with an emergency, any emergency, is that there's usually no time to prepare. Because there's no time to prepare, we all need to be drilled and grilled in terms of managing this. And therefore, this has got to be a second nature to us in terms of managing how women are managed when they are actually bleeding. And therefore, fire drills have got to be done routinely in our facilities so that we reduce the death of women. We also need to have readily available equipment in our labor rooms, in our delivery rooms, so that when these emergencies arise, we know for sure that we can tackle them head on. Maternal mortality is increasing in South Africa because of various things. I've also mentioned the obstetric hemorrhage. But one of the things that we've seen is that bleeding at Caesar is a bigger problem. And knowing fully that if you look at the audits that we have, cesarean section is rising in our institution. We are seeing more and more patients getting cesarean section, others coming back for a repeat cesarean section. And this predisposes them to bleeding either at Caesar or bleeding after Caesar. And therefore, we need to be equipped and we need to know exactly what to do and how to manage these women. And the aim of the talk is for us to identify that, and we aim so that everyone, right from the nursing sisters up to the specialist, should be able to manage these patients when they come in with this antepartum hemorrhage. What are the causes of antepartum hemorrhage? Because before we manage patients, we need to know what has caused them to be in that situation. What are some of the causes of the antepartum hemorrhage that we see commonly? Abruptio placentae related to hypertension or trauma is a common thing that we see in our units. Rupture placenta, a ruptured uterus, placenta previa, and bleeding from the genital tract. And sometimes patients bleed and we can't really say what the problem is, and we call that antepartum hemorrhage of unknown origin. But we know that underlying that antepartum hemorrhage of unknown origin is an abruptio that is able to manifest itself within 24 hours if we observe that woman quite closely. We always say that prevention is always better than cure. So for us to prevent antepartum hemorrhage, it is very, very important for us to understand the issues involved in that process. Routine iron supplementation of our women, who we know most of them are coming from low socioeconomic background, would play a very role in assisting us so that they don't go in labor with an anemia that will cause them to have a postpartum hemorrhage. So we need to supplement them with iron. We need to be prepared and anticipate antepartum hemorrhage. Women that are at risk of antepartum hemorrhage, they need to be assigned to a correct level of care so that when they go to deliver, we know exactly where they are supposed to deliver. They don't just deliver in a level of care that is not well equipped to manage antepartum hemorrhage or even postpartum hemorrhage. We need to use a pathogram so that we prevent a prolonged labor to these women, which will subsequently give them another kind of bleeding, which is called APH. We need to monitor their vital signs, and when we do that, the early warning charts are very, very important that we should use. In any labor room or in any unit in the country that is conducting delivery, we need to have antepartum hemorrhage boxes so that when the emergency arises, we know exactly what to find and where to find. It is always a big problem. If a patient comes in with antepartum hemorrhage, then everybody has got to run around and not know what to do. But if we do our fire drills, and if we know exactly where the APH box stays in our labor room, then it won't be chaotic. All of us would know exactly that here's a woman coming with antepartum hemorrhage, and here's an APH box with all the available supplies that should be there, and that are readily equipped for managing this woman with antepartum hemorrhage. Antepartum hemorrhage or hemorrhage in general is a problem because whenever people bleed, we tend to underestimate the amount of bleeding. Because they bleed, we wipe off everything or we change the linen and they bleed, and sometimes we don't even know how much they have bled. The other problem apart from underestimating is the physiological changes that accompany pregnancy. For instance, in pregnancy, we know that there's an increase in the plasma volume of many of women when they fall pregnant. And it may take a little bit of bleeding or severe amount of bleeding before a woman starts to manifest the clinical signs of bleeding. And therefore, that makes us to be very, very careful when we're dealing with women that are bleeding. Must always understand that when they bleed, they may not actually have signs and symptoms immediately. But having said that, it does not mean that we should relax and not manage them. Mothers can lose up to 35% of their circulating blood even before showing clinical signs of hypovolemia. What are the clinical signs of bleeding in these women? They will have pallor. They may have an increase in the heart rate. Later on, they may drop the blood pressure and get confused with reduced urinary output as accompanied by fetal heart rate abnormalities. And sometimes they may have obvious bleeding when they come, and then we say, this woman is bleeding. When signs are there, it is very important for clinicians to interpret them. It is very unfortunate when we see signs as clinicians and then we don't interpret them, because if we don't interpret them, then that leads to disaster. So whenever a blood pressure drops, whenever an HP drops, whenever somebody is bleeding, whenever there's a tachycardia, we must always try and interpret those signs, try and see how to add them up so that they make a meaningful interpretation to us. How do we manage patients with antepartum hemorrhage? I generally say when I talk to people, it is very important when you go and approach a patient that is bleeding, you greet that patient. Because by greeting the patient and saying hello, then you are able to know and ascertain the level of consciousness of this person. Because if you go in and say hello, you are able to see that this lady or this woman is conscious, is fully conscious, and that she says is quite good. Whereas if you go there and she's been bleeding and she's collapsed, and you go and you say, hello, Mrs. Steele, then you will know that this woman cannot respond, and then you raise an alarm and everybody comes in. So going to the woman and greeting her makes you understand whether she has got a GCS that is fine or not. Secondly, when you talk to this woman and say hello and she responds to you, you are able to ascertain the airway of the woman, whether it is open or not, because sometimes she may be rolling in and out of consciousness. And if she starts mumbling and saying things that are irrelevant, you are able to see and hear if there is a problem in the airway. And if there's a problem with the airway, you do a throat head tilt, chin lift, and a throat thrust maneuver, and you put up an airway and you are able to attain to the airway of the woman. And it is also important when you say hello to them, you look at them and you are able to see that they are still breathing, they are alive, they have a good GCS, and the airway is open. And because this is an emergency, one needs to call a cab. You need to remember to call a cab. You call everybody, but the cab is very important, which is your circulation, your airway, and your breathing. With the circulation, one will need to put up 2 IV accesses of IV lines. And while doing that, take blood for FPC, for UKE. And if this patient, you see other things, you may draw blood for other things that you are worried about. If blood is not readily available in the unit, you can start giving IV fluid so as to keep the blood pressure okay. You need to catheterize this woman because by putting up a catheter, we are actually monitoring the resuscitation of the patient, because what comes in needs to come out. So you are able to see whether the woman is getting adequately resuscitated or not if she's got a catheter. We must also be very careful and know that we may have coagulation problems here, and therefore these women can bleed for a very prolonged time, and we must anticipate that and be ready for that. If we look at the abruptio placenta, abruptio placenta is nothing else but the premature detachment of the placenta from the endometrial lining. We all know that when somebody is in labor, you deliver the baby first, you clamp the cord, you cut the cord, and then you deliver the placenta with controlled traction, modified Brandt-Andrews maneuver, and then the placenta comes out. But in the case of an abruptio, the placenta detaches itself while the baby is inside the uterus before the baby is born. And that becomes a very big problem because it means oxygen supply and blood supply to the baby is cut, and therefore may lead to the compromise of the fetus. And also because there's bleeding, the mother's circulation may also be compromised. Now, abruptio placenta can either be revealed or it can be concealed. In other words, a patient can present with PV bleeding that we see, and we know that she has got antepartum hemorrhage and she's bleeding. It's antepartum hemorrhage because she's bleeding after a viability or 28 weeks from the genital tract. Then we say this is revealed abruptio. Sometimes patients may not present with open or visible bleeding, but with all the other clinical signs of abruptio, and then we may call that a concealed abruptio. These patients usually present with tachycardia, pallor, hypotension, an abdomen that is woody hard. But if the placenta is posteriorly situated, the abdomen may not be woody hard, and therefore one needs to keep that in mind. Patients may also present with severe abdominal pain. When you look at the patient, the abdomen is tense, the uterus is difficult to palpate, they are shocked, and the degree of shock is not appropriate to the amount of blood loss. In other words, patient has bled very little dark blood, but she is shocked, and we need to be careful. She may suffer complications of renal failure, clotting abnormalities, and we always need to anticipate that, and we always need to be able to manage it. How do we manage then a patient who comes in with these clinical signs, who's got an abruptio placenta or premature separation of the uterus from the uterine wall? As I've said, you call for help, and you tilt the patient to the left-hand side so as to prevent the hypotension syndrome, and you check the circulation. As we have said, you put up 2 lines, catheter, monitor resuscitation. You draw blood, you check the airway, and you check the bleeding. It is very vital that when you have managed the patient and you have made the diagnosis of an abruptio placenta, you resuscitate these patients fully before you do anything. If the baby is alive after resuscitation, rupture the membranes while you are busy organizing theater. And if the patient is far from delivery, is not fully dilated, you will need to take that patient to theater as soon as she's stable, and therefore you need to do a cesarean and deliver because the baby is alive and the mother is fully resuscitated. If the baby is dead, we still need to resuscitate the mother. Then we need to order minimum of 4 units of PEG cells and 4 units of FFPs because there is a coagulopathy associated with severe abruptio. We always say an abruptio that kills the baby is severe enough to require minimum of 4 PEG cells and 4 FFPs. And therefore, when they are there, you rupture the membranes, you put up the blood, and you put up the FFPs. If you are far in a referral hospital, please, you need to refer these patients immediately because a delay in managing these patients will lead to their death. They need to be delivered within, to be in established labor within 6 to 8 hours, and then you can deliver the patient NVD. The patient will go for a Caesar for any other obstetrical indication, or if your resuscitation is not in keeping with the progress of labor, then you will need to resuscitate the patient and take her to theater. Postpartum, I'm sure Prof. Focus will talk about that. These patients are at risk again of bleeding, not only antenatally, but postpartum. And one needs to be very careful about that because they will bleed postpartum. And therefore that you need to anticipate and need to be able to manage it. And I think Prof. Focus will talk about that a bit later. What about placenta previa? Placenta previa means the placenta is before the presenting part. And we normally see placenta previa in patients that have had previous scissors before. As I've said, currently in the country, we've got an escalation of the cesarean section rate. And because of that, we must scan our patients because we don't want them to come in labor, or we don't want to present them without us knowing that they've got placenta previa or even placenta accreta. So we need to look at these patients. Patients who've had instrumentation of surgical intervention to their uterus or evacuation of their uterus are also at risk of placenta previa. So we need to take a full history, do a thorough clinical examination, and then we know that these patients have got placenta previa and make that diagnosis. What are the signs of a patient with placenta previa? These patients, they normally present with PV bleeding, but their PV bleeding is usually bright red in color. The amount of blood loss is proportional to the degree of shock that the patient suffers. And usually the fetus is alive, and when you examine the abdomen, you find that the abdomen is quite soft. If the patient has stopped bleeding, then we just need to admit the patient for bed rest, no digital examinations, and then we can give her steroids so that if she delivers before 34 weeks, we know that she has had steroids. Otherwise, at 37 weeks, we can deliver these patients, or at any time when the patient bleeds severely to a point that we cannot keep up with resuscitation. We will need to see these patients on a daily basis and examine them and know that they are not bleeding. Should they bleed, their management is the same. We call for help. We still call a CAP, circulation, airway, and breathing. We must cross-match these patients. And as I've said, if it's before 34 weeks, steroids will be appropriate. At this point, I just want to put up a case presentation that is not related to the placenta previa that we're talking about. And I just want to show you something that we had. It was a week ago when we were preparing. When I was preparing, I happened to have this case, and I felt that I should share it with everybody, especially people from Limpopo. In our unit here in Port Elizabeth, a 27-year-old para 2 grav 3 came at 33 weeks 2 days by early ultrasound. She was Rh positive, RPR negative. She had been culturally tested, and she was positive, but we didn't know her viral load and the CD4 count because in her problem list, she had defaulted antenatal care. She was a previous Caesar, and when she came in, she complained of low abdominal pains. She was not bleeding per vagina. There was no rupture of membranes, but she was bearing down with every contraction. I am not too sure if there's anyone who wants to venture and say what the problem could be here. You are at liberty to come in and talk. Here's a problem list: 27-year-old, previous Caesar, defaulted ANC, comes in with PV bleeding and low abdominal pains, bearing down with every contraction, no rupture of membranes. When we examined her, she was not pale. She had a blood pressure of 136/95. Her pulse was 73. Her HP was 11.6 grams per deciliter. Chest was clinically clear. First and second heart sounds were normal. There were no murmurs. The abdomen, she had generalized tender peritonitis. Head was not engaged. On speculum and vaginal examination, she was not bleeding. Is there anyone who still wants to venture in coming and make a suggestion to us? Any of us? No one. Okay. We examined the patient. We came up with the diagnosis of uterine rupture. We put up 2 lines. We took the patient to theater. We did a laparotomy. And indeed, at laparotomy, she had a 3-kilogram baby that was in the abdomen. Uterus had ruptured. And that brings me to our next cause of antepartum hemorrhage, which is uterine rupture. We are seeing a trend, an increasing trend in the cesarean section, and patients are falling pregnant after the cesarean section. And with that, with those pregnancies, we're seeing an increased trend in uterine rupture that most clinicians often neglect, and most clinicians, they forget about. Uterine rupture has become a common problem. Patients may present with abdominal pain. They may present with vaginal bleeding. Patient may be shocked, but you saw in the patient that presented, she was not pale, she was not shocked, HP was 11. Patients may present with pain over the scar, which is continuous, and there could also be fetal heart rate abnormalities. When we do a digital examination in these patients, we find that the head is receding or going back. And when you do a catheter specimen or you do a urine dipstick on these patients, you may find that the patients have got either a macroscopic or a microscopic hematuria. Once you have this clinical picture, one needs to be mindful of a uterine rupture, which is something that we see. And if we fail to diagnose, it will lead to an increase in maternal deaths. Management of these patients is like any other patient. We need to resuscitate the patients. And then we need to take the patient cross-match, take blood for FPC, UKE. If the baby is not alive, whether alive or not, we still need to take the patient to theater, do a laparotomy, and look well after these patients after they are delivered. Because even after delivery, they are not out of the woods. I just want to say, whatever we do, let us remember that antepartum hemorrhage is a reality. Antepartum hemorrhage still kills a lot of women if we fail to make a diagnosis. Obstetric hemorrhage is a major contributor to maternal deaths. Fire drills, weekly fire drills, correct use of pathograms, an antepartum hemorrhage box, very, very important for these patients. Reading the clinical signs, interpreting them, and making a correct diagnosis is very important. And eventually, managing the patients correctly and preventing bleeding or further bleeding is quite important. Thank you.
Thank you very much indeed, Professor Mabenge. My name is Peter de Jong. I'm sitting here in Cape Town, and I'd like to thank you for a very insightful and illustrative talk. I'm wondering if Dr. DeCarlo Muava is available. If not, I'm going to take the lead in thanking you very much indeed and hoping we can have some discussion. Are you available for some discussion?
No problem. I am available.
Right. Now, the first... I'm listening.
Yeah, the team is available. We can hear you. Go ahead, Doc. You can go ahead.
Is that DeCarlo speaking?
That's DeCarlo speaking. He sounds like a girl, but it is him.
DeCarlo, can I just bring up, I just want to thank Professor Mabenge and just bring up one or 2 points. The first point is the blood box. I saw in your pictures, the slide of the blood box, you did have misoprostol, but I didn't see any cyclocapron. Do you have cyclocapron available in the blood box?
Usually our cyclocapron is kept by the sisters somewhere, and they keep it at a lock and key. But it depends on what hospital or where you are. But cyclocapron is something that we should have as well, because it does really assist in terms of bleeding. Because sometimes these patients, as we have mentioned, may have coagulation abnormalities, or they may bleed to a point that you can't arrest the bleeding. Even at Caesar, sometimes when they bleed, you may need cyclocapron, and therefore our anesthetists and our sisters in labor ward, in high care, they always have cyclocapron ready for us, and we normally give it IV to them.
Excellent, because it's definitely a drug at 1 gram intravenously, 6 hourly, and can also be done orally, obviously. It saves lives. There's very few side effects, if any, and you can save a huge amount of lives by giving it early. Don't delay. Don't wait 15 minutes. Give it immediately. The second question I want to bring up is maternal mortality meetings. Do you think it's important for people to have regular maternal mortality meetings?
Just like fire drills. In our unit here in Port Elizabeth, I'm sure some have visited here, they will tell you, we have our perinatal meetings every Tuesday, 2 o'clock with the pediatricians, because we need to review. You can never improve your circumstances if you don't audit yourself. So audits are very, very important for any unit in the country. Just like fire drills, that they should be done weekly, because it's easy for people to be complacent and forget how to do things. So what we normally do, we stage scenarios, sometimes aware, sometimes unaware. We just ask a patient to pretend as if she's bleeding, so that we evaluate and then we see how things are done. Also, during the resuscitation, it's very, very important that people know exactly what roles they play when there's a resuscitation, so that each one knows that he's in charge of the red box, is in charge of this, and each one is in charge of that. And then every shift, people must go and check the equipment. If it's there, it's functional and it's working.
Yeah.
So, review of maternal deaths, audit meetings, very, very important.
Do you have the midwives coming to your maternal mortality and audit meetings as well?
They are an integral part of it, and therefore we can never do anything without midwives. They see this patient. We also have an MOU right on site, but when we have perinatal meetings and fire drills, the MOU staff, they also come to our perinatal meeting.
What training do you have for junior staff for cesarean sections? And the reason I ask is you mentioned the very important, vital part that bleeding plays in maternal mortality. So do you have special training for cesarean sections in especially the junior people that are doing these procedures?
We have a senior consultant who is retired, but who's doing our...
What's his name?
Dr. Makiwane.
Dr. Makiwane?
Yes, Nandumiso.
It's Cecilia Makiwane.
No, as in Cecilia, but she's Dr. Makiwana. Okay. She takes the interns and she trains them on how to do a safe cesarean section. And when Dr. Makiwana is not there, then we have new registrars and new medical officers, and we always insist that a consultant must be there. We also have a consultant, which I would encourage others to do as well. Must be a consultant who's covering labor ward cesarean section theater, so that when there's a problem, he is there. He trains the registrars. He shows the junior guy how to do things. They must never touch a patient without having gone through a safe cesarean section tutorial.
I seized on Makiwani because I worked at Cecilia Makiwani Hospital Sipetle in Ndansani for many years before your time. The next thing is this, ambulance transport. When I was at Cecilia Makiwani, I used to drive an ambulance. Do you have, and also for DeCarlo's point of view, do you have proper dedicated ambulances for the clinics to allow people from the clinics to go directly to the hospital for obstetric emergencies? Or is it a shared ambulance?
I'm happy that the MEC of Limpopo is there and she has welcomed us. And I would really encourage that even in Limpopo, we have a baby lance or a dedicated ambulance for maternity.
Good.
That will reduce the maternal mortality significantly. We had a baby lance that was around here, but because of Corona and because of the robbing just before Corona, we struggled a bit, and that had put us into serious challenges. But it is very important that there must be a dedicated transport, dedicated ambulance for women that are pregnant to reduce their mortality.
Absolutely. One of the most important ways of reducing maternal mortality is by affording the same rights, equal rights to women as to everybody else. You mentioned the escalation of cesarean section rates. Why is this the case, and is it of concern to you or not?
It is of concern. We've just done a study, and it was in the ONG Forum recently, where we found that we had a cesarean section rate that was almost 50% at Dora, which was a very high.
Sorry, almost what percent? 60%?
50.
Okay.
Yes. It's quite high. It's worrying. And one of the things that we have done as the Eastern Cape and Dora particularly is to audit our cesarean sections. Very important. So that we know exactly if we are taking a patient for a fetal distress, we know that there was fetal compromise. If we say there's a CPD, we know that there was a CPD. And that assists us in terms of knowing exactly and training our registrars how to do things. Things like breech, for instance, we are still trying out external cephalic version so that we reduce our cesarean section rate. And one of the things that we saw that almost increased our cesarean section rate here at Dora was failed induction of labor. People were getting impatient, and for non-urgent indications, they would just resort to a cesarean section. As a result, now we're auditing everything. So audits, as we have said, are very important in terms of looking at cesarean section rate. However, if a patient is referred and people say that there's nothing more that can be done, I think we should not be delaying a patient in giving a Caesar if a Caesar is a solution to the problems that the patient has.
Thank you. We're talking about cesarean sections next week. Is that right, DeCarlo? And
yeah,
we can
Pete,
yeah.
Pete, how's that, Pete?
Hi, DeCarlo.
I'm good. I'm sitting with my boss here. She just want to respond to Prof. Mfundo's assertion about the obstetric dedicated ambulances.
Yes.
She's on now. She's going to talk about that now.
No, thanks very much, Prof. Mabenge, and thank you very much for that presentation. It really revived my obstetric skills, because I will need that. I miss the profession. It was fulfilling to be on the side where you are than here where I am with regard to politics. Because when you're a clinician, you want to implement things that are really to the benefit of the patients. And unfortunately, mixed with politics, it becomes difficult. You most sometimes step on the toes of others, and that's where problem starts. But let me also indicate to respond to Pete to say, I think as a province, I've got the head of obstetrics here with me. What we have agreed in terms of the maternal death review, immediately after any maternal death in any facility, there should be a meeting that is called within 72 hours, wherein all the midwives around that area and the doctors who were involved, and also the district obstetrician must be able to be part of that review to begin to understand what could have happened. And they must, after that, send a report also to myself and the HOD so that we can, if there are managerial issues that require our intervention, we have got to intervene. And then following on that, the institution on a monthly basis, they must still have their own monthly maternal death review. Then we also have got a provincial maternal death review. That's where you would have the head of obstetrics and the head of anesthesia, also with the DDG in the province who will be chairing those particular meetings. And sometimes when the HOD or myself is available, so that we can look into that. That's how we're even identifying hospitals that are problematic and how we can intervene and support them. So part of the issues that Peter has indicated, which we picked up, was the issue of transportation, because we have realized that our pregnant women are competing with drunken stab wound for an ambulance to go to facility. And
Say something. Drunken stab wounds, and then it went dead.
I think we problems.
We could, within the next 5 years, we would be having those particular, that are obstetrics. If I'm driving on the road and I found, because they are labeled, they are branded obstetric ambulance, I have a right to stop it. If I find it carrying a drunken stab wound, you should account to me, because people, unfortunately, the drunken stab wound becomes a more of emergency because blood is pouring than a pregnant woman, whereas they're missing the point that a pregnant woman might sound stable now, in the next minute she just crash. So hence we're saying, as a province, we've taken that decision to say annually we've got to address this thing, and we must thank Dakaro here and Dr. Baloyi to say we are pushing that. Last 2 weeks back, the Premier has launched the first batch of obstetric ambulances in the province. So once I got the buy-in of a Premier, you must understand that is going to happen. Even if I'm gone, it is there as part of an annual budgeting to say budget for obstetric ambulance until such time we know we've got adequate transportation of pregnant women. Thank you.
Thanks, MBC. I just wanted to add one or two things that after these meetings, one of the things that I found with our doctors is that they really need debriefing. We need to support them. We need to debrief them. We need to support them so that they don't feel discouraged, because at times they get discouraged and they don't want to work in obstetrics anymore. So debriefing is very, very important for us to do this. Also, ESMO e-training, because we train our interns and we train our registrars on ESMO. We also train our midwives on ESMO. The midwives, they need to be trained in terms of ESMO so that everybody understands exactly how to manage obstetric emergencies, including bleeding, which is antepartum that we're talking about. So training is very, very important, not at tertiary, at a district and all over. Any facility that delivers must train patients.
Okay, thanks very much. I'd just like to, I've asked enough questions. I just wanted to say one thing to DeCarlo's boss, Dumasile. There are many, many reasons for women dying. And some
I'll be in trouble now. My boss is not Dumasile,
But it says there, your boss is Dumasile.
No, my boss is Phophi. You should know that name by now.
Yes. Anyway, more The important thing about maternal deaths and maternal problems, mortality and morbidity is there's many causes. And one of them is training. One of the most important is women's rights. And we're not going to have much to say about that now. But the other thing, of course, is systemic problems in the hospitals. I do a lot of medical legal work, and you can't blame, as you said, Professor Mabenge, you can't blame the doctors necessarily. Many of the things that cause women to die and women to suffer and babies to die is in fact systemic problems. They may be political, but they're often lack of facilities, lack of training, lack of support. All these things play. And when we have these things, DeCarlo, we're going to address all these issues. The ambulance transport being one of the most important things, as your boss says. And you've got to ring fence that and not let those ambulances go to anybody else. They must be apportioned to the clinics, and they're only for pregnant women and maybe babies as well. You know, maternal and pediatric issues, and not for drunken men that stab each other. The final question I want to ask Professor Mabenge, and you too, Carlos, do you have freeze-dried plasma there? You have FFPs, you mentioned that, fresh frozen, but do you have freeze-dried plasma? Because if you do, that's a wonderful resource you can have in a clinic, is that powdered FDPs that you mix with saline, and that can also save many, many lives.
We do have it. When I was in Durban working in hospital, we used a lot of it. In my hospital, we do have it, but you find that for one reason or another, they use it when they can't get hold of the FFPs from the blood bank. But as you say, we should use it.
And it's great stuff. It saves lives.
Great stuff. It does. It does indeed.
Yeah,
and it's also so it prevents hypertension as well. Sorry, DeCarlo, you carry on?
Yeah, I was just saying we also have it in Limpopo, Pete. I must say I see Prof. Sue Focus as well, and we also have almost 207 people actually listening to us from different cell phones. And in those numbers, there are groups of people. I know in multiple hospitals they're using one computer to listen. So let's just acknowledge the people who are here. And if there's one who has a question, please, can we ask those questions now? We are privileged today, we have our MEC as well, but it should be related to antepartum hemorrhage, not politics. So, so if any of those people who are out of those 200 and something computers who are logged in, if you have question, please, through Pete, you can ask. And I would really like Prof. Sue Focus as well to talk to add something on this. Thanks.
Can we address the questions to Professor Mabenge and maybe to Sue Focus? I think I've spoken enough now. Let's let Professor Mabenge, you too, DeCarlo, and Sue Focus speak.
Prof. Focus? I see that someone asked what are the indications for seizure in patients with an abruptio? And we have already mentioned that the indication for cesarean section in an abruptio is really, as in all other patients, like any indication for an obstetric patient. But over and above that, if someone is bleeding and we cannot keep up with the resuscitation and we think that she's got a uterine rupture, for instance, a previous seizure or whatever, then those patients will qualify for a seizure. Otherwise, we always aim for normal vaginal delivery in these patients. Correct the coagulopathy, aim for NVD, and then to preserve the seizure for other indications. Prof. Focus, I don't know whether I wanted to say something.
Yes, thanks very much, and thanks for inviting me to be a part of this process. I think it's very, very exciting. Just 2 points I thought I'd make. The one precisely on that, the cesarean section in the Abruptio Placentae. You know, I've just finished looking through all the maternal deaths from hemorrhage in South Africa for the last 3 years, because that's my job on the confidential inquiry. And sadly, there's still a lot of people who are doing cesarean sections with abruptio placenta when the baby has died. And when you do that, you actually then often cause a maternal death because the mother has developed a coagulopathy. Now, sometimes it's because they don't know, they haven't received the kind of training the Prof Mabenge has just given you, but sometimes it's because they actually thought the baby was alive. They put on a CTG and it recorded something going at 120, which they assumed was the baby's heartbeat. And in fact, the baby had already died, and they were picking up a maternal tachycardia. So I think, the one sort of message is, when you think the baby's alive, check the baby's alive, if possible, with an ultrasound scan. Because if you then rush into doing a Caesar, and then the mother dies, and actually the baby was already dead, you've actually now caused 2 deaths rather than 1. And then the other just comment I wanted to make in general, I think it was, I might not have got everything that was said because my internet wasn't very good, but in terms of the transfer of patients with APH or PPH, I do believe Limpopo now has got the anti-shock garment, and that can be used. That's very important for transferring women with PPH after vaginal delivery, after cesarean section, but actually it can also be used for one with APH, as long as you don't put on the panel that goes around the abdomen. So I think, as well as the great initiative you've got there with all these new ambulances, I think if they can have the anti-shock garments, that will also be very helpful. Thank you.
Thank you, Pete. If you can allow me, Pete, there's a young lady from Western Cape. Her name is Anika Domingo. She wrote on the chat, she says they have FDPs in the rural district of Western Cape in Bradesdorp. Why I'm picking her one which came just in front of me is because she actually sent me a very touching message. She said that when she was a ComServe in this district, in the rural area, she discharged, I don't know if she would like me to just say it in front of everyone, but because she didn't have a lot of training in ultrasound, she discharged a patient with queering unruptured ectopic, and the patient came at a later stage with ruptured ectopic. And lucky enough, she was able to resuscitate and patient did well. But what I'm putting across is this education, which Prof Mabenge has been saying, that most of these ComServe and young doctors, when they pass, they may not know these ultrasound skills, they may not have this kind of education. So this kind of program, Pete, I think is so important, and I'm so glad it's well received by everyone. Pete, I have other messages here. Would you like to read a message from the chat, Pete, from your side?
Okay, here we go. It's over here. Dr. Myler, to all panelists, we suffer with ambulances. We don't have ambulances. You've got to wait 2 hours before an ambulance comes. And, that's as we said. I think if everybody was treated equally, in other words, women's rights were as important as everybody else's rights, there would be a force available to make sure that the clinics did have ambulances. I know that they had them in the Free State. It made a huge difference to reducing the maternal mortality. And that's so important to have proper transport, particularly in rural areas, to centers where women's lives can be saved. That's another thing. And then another question over here, Dr. Mwaba, to all panelists, who is training at the district hospitals? We don't have ambulances, period, especially in the district hospital. I don't know where the ambulances are. The cesarean section rates increase because of high teen pregnancy and hypertension and herbal remedies. So I think that's, again, a problem that starts prior to pregnancy. How do we reduce the teenage pregnancy rates? And I should think family planning is so important there. And hypertension means we've got to have proper clinics and herbal remedies. Once again, that speaks to education. Herbal remedies, particularly in the Northern Cape, is also important because they can cause severe contractions of the uterus. And there is from Israel Santi, dear colleagues, will the recording of the session be shared with the rest of the attendees? And the question is yes. Just email
yes.
us. Yes, we will. And the email must come to us and we will do it. And as Anika said, they do have FDPs. Says Dr. Deirdre, will the PowerPoint presentation be sent via email or put online? And the answer is?
Yes. Pete, I want to just put another important matter this side. We got funding from SAFAID. I'm so proud of this team. With this funding, it's a private funding to just complement or to add on the obstetric ambulances the MEC has been talking about. For Malamulele and Helena France, we have made a private contract with the private ambulances, and we have one of the ambulances outside actually. So from now on, like here where we are in Helena France and in Malamulele, they have, with that fund, we are using it for private obstetric ambulances, where they will use it for very shock patients who need advanced care. So this actually will be generating something. I think that deserves a clap. SAFAID, I can see Dumisile is here. She doesn't really want to talk, but I'm pushing her to be able to come and just talk, because their contribution actually is very, very welcomed. Can I ask Dumisile to just have a word? Because we have made that contract with the private ambulances, and I see Dr. John, yeah, the ambulance is outside as well, so MEC will have even to go and inspect it as well. Dumisile, please just say a word for 2 hours.
I've lost her.
Good afternoon. Thank you so much for attending this presentation. I would really like to appreciate the presence of our MEC. She really did make an impact on the success of this project. No woman should die, and no child should have an APGA of 0 or of 0 score. So we really appreciate the support that we are receiving and the partnership, and also the support of the presenters and the moderators. So for now, I think that's all I can say, so that we won't waste much time. Thank you.
Brilliant. I hope you didn't mistake her feminine voice with my voice. That was not me. Okay, so Pete, take it over, please. I just wanted to put that across as well, so that the people who are listening from Helena France and Malamulele, they know that they can be able to call that private ambulances. Okay, so you can go ahead.
Just before I hand over finally to Professor Mabenge, there's 2 more questions that have come up, and they're very important questions. The one is from Dr. Ramathuba. Am I suggesting that cyclocapron should be given for APH even with live baby? Yes, of course. Yes, yes, yes. Cyclocapron is safe. It saves lives and it prevents bleeding. Obviously, if a woman is bleeding, you're going to deliver as soon as possible if the baby is alive, and cyclocapron may be of use over there. And another final question, regarding Abruptio Placentae in the context of a previous cesarean section, do we do a trial of labor or go to a cesarean section? Definitely. The baby is alive with an abruption and a previous Caesar, you go directly ASAP to another cesarean section emergency. Thanks very much. And hang on, there's one last question over here to from Dr. Klangwa. We don't have simple maternal books. We don't have BP machines, urine dipsticks, and HGT, that's blood sugar machines at the clinics. Almost all of the Sekukuni clinics don't have those. So that is a political problem over there that you're going to have to address to Carl. I don't know how far you are from Sekukuni land, but...
are they saying that they don't have, it's in the storeroom? Yeah. Because, you know, my experience with the a year which I've been here in Limpopo is that you will find people say they don't have 1, 2, 3, and 4, and they didn't go to the storeroom to have a look. I'm not saying that that's the case in Sekukuni, but I'm just saying that we must just expand and see if indeed it's because the person who's supposed to be ordering hasn't done it, or if they have done it and they've put it somewhere which the people are not able to access it. But it's a valid point. I don't know if the MEC would want to say anything, or yeah, but MEC, would you want to say something? Yeah.
What's the name of the hospital there, MEC? Is that Jane Fur's hospital?
We are here. We're in Helen Franz Hospital.
No, in Sekukuniland.
It's Kukuniland. It's Jane First Hospital.
Yeah,
At least
that's
the good thing. The good thing is that from tomorrow, I will be working in a hospital since Kukun, and I'm going to prove you that this person is lying.
No. We don't use that word over here. No, we're all on the same side. I think that's important. Nobody's lying. Nobody's in opposition.
All right.
We're all on the same side here.
Thanks very much, Pete. What I'm saying, maybe let me withdraw the way I put it. But just to say they are not economic, they are being economic with the truth. Why am I saying this? If you remember, Kukune was our hotspot when it comes to COVID-19.
Yeah.
And as a province, we launched what we called community-based approach towards fighting COVID, wherein we empower our nurses at the clinics and our community healthcare workers to say, let's now fight COVID in individual households. We will then say a community healthcare worker goes and screen and profile diseases by checking your blood pressure, your blood sugar, and all those other comorbidities. They are working with professional nurses. We say one community healthcare worker, we assign 160 household. And then 10 community healthcare worker, we assign them one professional nurse. Then we brought in the GPs in that. Why am I saying this? It's because all those professional nurses, we equip them with the blood pressure machine, the blood sugar glucometers, and even for those who are in Vembe and Mupani, even your malaria test kits, your HIV test kits, and all that. Because we're saying, let's not only deal with COVID, because we've seen the mortality is high when it comes to comorbidity. So that's when Sikukune was the area where I was physically working there in those clinics with those community healthcare workers. That's where we put an investment. Hence, we reverse that a challenge, which Sikukune was our epicenter, and later on, it becomes one of the best performing district in terms of COVID-19, because that was our approach. So good thing is that tomorrow I will be in Matala Hospital. I will also be in Grobestel Hospital. We are there with the very same team here, where we are moving to because of this rural health project that we want to see our rural hospitals. I'll be going with all these medical specialists. So if we don't have those BP machine, we will go to the storeroom and make sure they're there. And to all the nursing operational managers who are here watching, to all the CEOs and nurse manager and clinical manager who are watching, if I find that in your hospital you don't have those vital equipment, I mean, those are just for you to screen patients. You can't say you are struggling with that. You're going to make me angry. You can see I'm already angry. If they are not there, well, that's a managerial issue which we have procured. They are there. And if you are not ordering them, and they are accumulating dust in some storeroom, you will have me to deal with tomorrow. That one I can't mix words when I speak about it, because I get angry. We can't lose patients because of minor things. That we cannot, and that we must not accept. And as professionals, we must stop blaming other people instead of doing our work. Not everything is about politics. We have got a responsibility. When you are an operational manager of a clinic, you are the MEC of that clinic. You are the president of that clinic. You must make sure the clinic is well equipped. People can't go all out complaining when we have put systems. Yes, we've got challenges and problems, but when you have political leadership that is prepared to support you, you can't come and say we don't have those equipment. That I'm not.
Thanks very much. We've got a lot of questions. There's Dr. Mnisi says we don't have proper CTG with graphic paper. We have one CTG that only shows the fetal heart rate and not maternal contractions. I don't know where that doctor's working. And then there's in the Mopani clinics, You go there, they say, doctor, there's no BP machines or HGT strips. Sorry, it's not political, it's just how it is. So I'm going there to review hypertensive and diabetes mellitus control with no vitals at all. Can you please go there? And the final thing is this, just getting away from clinics and BP machines and strips and CDG paper, it's a question of a clinical nature. Does a district general hospital have to have a consultant that can do hysterectomies? And I would say yes, because if you have a woman that's bleeding, this blood cannot be stopped, the uterus won't contract, then you would have to do a hysterectomy as a life-saving procedure. Would you agree?
Yes.
And Carla, can you take over from now, please?
Yes.
All right. Thanks, Pete. Thank you so much. I always say, Pete, when I am a government employee, and I say that a government I work, and government is not the buildings. Government is not. When you go to a hospital, it's not the buildings. It's me. I'm the government. So if I'm not doing my part, I can't stay on the queue or wherever I'm in the bank and I'm saying, hey, my government, they I work. Majority of us, we are employed by government. And that's why for us, I think we really have to say, before you say this and this is not there, let's get and find out who's supposed to be doing that. Because half of the times you find that the reason it's not there, it's maybe like with the PPEs. You find when I go to the hospital and then there's no PPE, someone is locking them, those PPEs. And when you go and look for it, the person who's locking it, we look launching. You understand? So we are the government. Guys, we have to understand that the government is not the building.
And we're all on the same side, Nicola. We're all on the same side. We must all work together. It's not Absolutely. Us and them. It's not this party or that party or you or you. It's all of us together for the sake of the woman.
Absolutely. I really agree with that. Okay, brilliant. So I think I'm not looking at the time because this talk and this process is actually so exciting. So Pete, you can continue from your side, and if we're about to be close to the end of the project, the people here, they're saying no.
We have to.
Yeah, I think we may have to. Prof. Mabenge, do you want to say the last word?
Yeah.
Okay. I just wanted to say it seems that there's a lot of issues regarding cesarean section in general. I just want to highlight a few things. A Caesar is an operation, and just like any other operation, it's got complications. So people mustn't just want to do a Caesar, as Prof. Focus has said, Caesar for an abruptio with a dead baby, thinking that they are just cutting corners, because something may happen and it may complicate, patient may bleed and die because of coagulopathy. So we must be very careful and understand, counsel the patients well. A Caesar is an operation and we must not just take it lightly. Obviously, if we manage an abruptio, I'm not talking about the Caesar now, I'm moving over to an abruptio because there was a question also here that says exactly what must we do. An abruptio, I think Prof. De Jonge said, an abruptio with a live baby. We must resuscitate the mother and expedite delivery. It's very important we do those things at the same time. Resuscitate, expedite delivery. If she's fully dilated or she's 9, while waiting for theater to rupture membranes, we know that she will probably deliver even before theater is ready. So it's very important for us to know exactly what to do. And I just wish to say training and retraining is the best thing that we should be doing for our doctors and everybody. And in summary, I want to say no woman should die in labor. My mother used to say animals, they deliver without any assistance, but they still are alive. We are privileged. We've got midwives, we've got doctors, and we know that things at times, they don't go well, and we will lose patients, but we must make it a point and work very hard so that if a mishap happens, then we understand exactly what has happened. So generally, no woman should die in labor because these women were expecting and they expected a great outcome. And the death of a woman for a community, for a family, is really, really a terrible thing. I wish to thank you for inviting me to come and speak, and I will continue joining the other sessions. And I want to thank the organizers of the program. Thank you for inviting me. This is a very, very good initiative. It's a very good program. In our culture, we say, umtu ngumtu ngabantu. In other words, you cannot be an individual alone there and think that you will succeed. I can assure you that don't be shocked when you see the Eastern Cape having the same webinar regarding maternal death. We are going to do it. Actually, we are in the process of doing it. So in any case, if something is beautiful, you copy it and you bring it home.
Yeah.
So we will do that. But thank you. And thanks to the MEC, it's very rare that we have politicians coming to assist us as clinicians. And I appreciate her time. Out of a busy schedule, she comes to listen and to brush up her skills so that when she goes tomorrow and there's an abruptio, she can resuscitate and put up 2 IV lines and catheter. Thank you, MEC, and thanks everyone.
Prof, well said. Pete, I see Prof Focus Nodding. Prof, you want to say the last word before we go to Pete, and we'll ask the MEC to close. Prof, before we go to Pete.
No, I just wanted to reiterate what an excellent initiative it is, and so good to have the MEC there. Thank you very much, and to see all the different arms of government working together, which is basically what we want to achieve. I look forward, I think, as Prof Mabenge said, there's been a lot of talk about caesarean section, so I think people mustn't be disappointed. I think next week Pete de Jong is going to be talking about how to do a safe caesarean section, and the following week I'm going to be talking about what to do if the woman bleeds at caesarean section. So actually the next 2 teaching things are all going to be on that, and I think it's really important. So if you feel your questions weren't answered this time, there will be lots of time for the next 2 sessions. And so thank you all very much. I think it's been a very exciting afternoon. I enjoyed the talk and also all the questions, and also hearing about the problems on the ground. Thank you very much.
Thank you, Prof. Thank you so much. Thank you, Prof. Just to reiterate, on Friday is the ultrasound training, and Dr. Verenga from Zimbabwe, who was trained by Kafos Nicoladi from UK, the godfather of ultrasound. So he will be there on Friday. So people must join still. We may not have the MEC then, but I'm sure she will be listening at the corner somewhere, and she will be noting your questions, and she will be noting all the issues which will arise from that. Pete?
Yeah, thank you very much indeed. It's been wonderful speaking, as Sue said, and as Professor Mabenge said. Thank you very much indeed. Who was it? Yes, Professor Mabenge said, if there's something good going on, let's share it. And I'm speaking next week on this caesarean section topic of a safe caesarean section. We also have webinars every Thursday afternoon, and the webinar this Thursday afternoon, that's tomorrow afternoon, is are we doing too many caesarean sections, or are we doing too few caesarean sections, and should a woman be allowed to choose caesarean sections? So I think you're all going to get invited to that as well. And the important thing is this: we're all on the same side, and ask away your questions. You know, nobody must be shy and nobody must get defensive. Let's all be honest. Thanks very much indeed for all your hard work, Takala, and that of the other people.
You're going to have a lot of Pete de Jong in this, and you guys will enjoy this. I really love it. Before I ask the MEC to come through, I just want to remind the people who can speak and understand Venda. The MEC is going to be speaking on Parapara FM at 8 o'clock for the whole hour. So if some of the questions you would like to ask, I know the host will be able to give you an opportunity to ask on the radio. On Parapara FM at 8 o'clock tonight. So you can still ask questions around there. Can I ask the MEC to come through to just close? Thank you.
Once more, good afternoon to our academics. I know you are the most busiest especially because talking is not your job description. Talking is our descriptions as politicians, but clinicians spend most of their time saving lives. I want to appreciate the fact that you have agreed to be part of this particular symposium, which is the first of its kind. And it will go a long way in making sure that we do things differently as the people of Limpopo. And doing things differently means more women will have their lives being protected and safe. It will make sure that we have all the learn from you what you are saying. I mean, I've already picked up a lot of things that I'm not going to tell you in public, that it was gaps in the department by just listening to your presentation, Prof. And I'm going, next time when you talk, you will hear more about saying, oh, the Limpopo has come up with this particular policy and that policy. And that's why I will try my level best to be part of all these virtual presentation, wherever I will be, as long as I've got data and I can connect, I will definitely connect and make sure I do listen and I do learn. I really would want to appreciate and to all those who are out there who are participants, you are welcome. Don't feel threatened probably by my voice to say the MECs here, we can't raise issues. We need to raise issues that are gaps, and let's be genuine and be honest. If indeed you can't, for instance, let me give an example. If you've got maternal clinic not having 1, 2, 3, 4, raise it so that we can fix it. But don't come and say, oh, the whole of Limpopo doesn't have 1, 2, 3, 4. Then we lose that, because it becomes these ones are just howlers. We don't want people to come here and howl. We're dealing with serious matters here. The life of a pregnant woman. To me, I am a woman. Let me venture into politics now, Pete. In our politics, when we go to elect MECs and the premiers, we always say 50-50. In our province, we said if a man is a premier, then 60% of the cabinet must be women. So you might realize that some of us are here because of that very gender issue. Now, if as a woman who is a premier, who is an MEC, I do not look at the interest of women, then I'm betraying the very same gender that I've used to elevate in my political life. That's the fact. If you are a mayor and you are a woman and you don't deliver water, clean water, you are saying women must go to the river and share water with animals, then you are betraying the very same struggle that elevated you. If you don't bring electricity and women have got to go climb mountains to get firewood and get raped and mutilated in the process, you are betraying the struggle of women. Similarly, if you are an MEC or a Minister of Health and you are a woman, and women continue to die because there's no safe ambulance, because there's no trained doctors to save them, because there's staff shortage, because of all those things that are managerial and political, then you are betraying the very same struggle of the same women that have made sure they elevated you. So maternal health care, it is my number one priority. Especially during the lighter note, Prof. Mabenge, you better go and have this sooner, in particular symposium very soon. We were under level 5 lockdown. Babies were being made. You need to wake up. Many women will be pregnant very soon. They will be requiring assistance. That's on the lighter note. Thank you very much.
Bye-bye, everyone. I won't say anything else. We'll see you on Friday. Bye-bye.